we'll have a little bit of discussion around that. If you can take a moment as we get into the warm up here to pull out your mobile device and scan the QR code that you see. If you're calling in, you can do the same thing virtually through this same slide. You can just hold your phone up to the screen and it'll give you access. We're gonna have some interactive elements to today that I hope will facilitate your participation and engagement, so that this can be less of a me talking to you for the next hour and a little bit more of a conversation. This is my 11th year with WPHP. I just consider it such a privilege to have a very mature, developed, and collaborative relationship with the Medical Commission. It truly is one of the pleasures of my work. I want to congratulate Dr. Murphy on taking over as the chair of the Medical Commission. Dr. Murphy has demonstrated a sincere commitment to WPHP's mission during her time on the commission, and I appreciate her support and collaboration, as I did with Dr. Domino, who many of you may not know that Dr. Domino was principal author of a paper with WPHP in 2005 that looked at risk factors for relapse among health professionals. It's actually one of the most cited papers in the literature today still. Was published in JAMA with Lynn Hankis and our former clinical director. So Dr. Domino has definitely been fully aware of what we do and who we are. An issue with aging physicians who are aging out of the profession and need a non-disciplinary and graceful exit pathway. Those kinds of things are the work that's sometimes getting done behind the scenes and outside of the view of you as commission members, but it's important work that we are able to do together. And I think that collaboration is really the envy of many physician health programs and other regulators around the country, and it certainly served me both in my role as the medical director of WPHP, but also in my role now as the chief medical officer for the Federation of State Physician Health Programs. So I have the opportunity to take our learnings from this work that we do together and disseminate it at a larger national scale. Have you all been able to access the Slido okay? We'll see how it works. I also will mention that my communications team, I think, is joining the meeting today. So they are quietly judging me and making me additionally nervous because, of course, they'll be giving me feedback when I get back to the office on Monday about how this all went from their perspective. I don't know what to do. Can I do that? And then will the slides advance? They seem to not want to. Is it going now? Now it's going. Okay. So this is indeed my annual report. We refreshed our mission last year to emphasize the fact that as we've been doing this work for 40 years in the state, we do believe that we are now a trusted resource for restoring the health of medical professionals. This is what gets us out of bed in the morning, is that work to confidentially support and provide exceptional outcomes for those that we serve, both reassuring safe practice and helping sustain our workforce. We think about a third of health professionals will have an impairing health condition in their career. That doesn't mean everyone who has a health condition or an illness will be impaired by that illness. But about 1 to 2% is what we aim for in terms of penetration of the licensee groups that we serve. That's who we think we should be serving. If we're serving too few of those, we think that there's unmet need. And so that's kind of our guide in terms of, are we able to reach those that need our help and assistance? Wonder if I can get rid of this bar. Because did Amelia leave? Oh, no, I got it. Okay.
And then see that pin?
It's, nope. I'm gonna drag it. Let's see if we just drag it out of view. Okay. So in terms of legal responsibility for reporting impairment, we're a mandated reporting state in Washington. 246-16200 requires all license holders, but others, healthcare employers, healthcare institutions, professional liability carriers. There's actually a whole host of people in that WAC section that speaks to the mandated reporting requirement for concerns of impairment. You can report to you. Or you can report to us. And of course, we would rather people report to us. And as long as there's been no patient harm, you can legally make a report to us in lieu of a report to the regulator. And we can keep that individual's circumstances confidential from the regulator and provide help and assistance so long as they don't pose a risk to patient safety. People who do make reports to us are protected. They're immune from civil liability in making a report, recognizing the chilling effect that would have on reporting if individuals were not protected in making a good faith report to WPHP. However, you're not immune from civil liability if there's a bad outcome and you fail to make a report that you should have made. So I think that's an important thing that we tell reference when they're calling us and they're asking whether or not they should make a referral. We outline some of these things in terms of what their requirements are. And that actually is very helpful. Not all states, only about two-thirds of states we think have mandated reporting. But I can tell you that it is often reassuring when an employer or a healthcare entity is calling us and asking about making a report when we point out to them that they actually have a mandated reporting requirement, and that if something were to go wrong. I've never seen the commission actually use this in a sort of proactive way to like discipline somebody, but I have seen it come up when if there is a bad outcome, the question being, was this individual or entity in a position to know that this individual might not be safe to practice? And then that's where this can really actually come into play. But we want people to be fully informed to the best of our ability about what the risk, benefits, and alternatives are of making a report to WPHP and the efforts to help people and mitigate risk. And then it doesn't want to, let's see, I'll try this. Oh, there it goes. So let's talk about a case for a minute. Now that we've talked about kind of what the mandated reporting obligations are, this is a 38-year-old emergency medicine physician licensed in Washington, also licensed in 2 other states, who's self-reporting a single DUI to WMC on the advice of counsel. Counsel who's representing them in their DUI case is aware of Washington's mandated reporting laws for gross misdemeanors or higher. And a DUI can be pled down to a gross misdemeanor in Washington State. Am I right about that, Mr. Rogers? Okay, so gross misdemeanor, though, is reportable to you all. And so worried because this individual is also licensed in other states about what the ramifications might be if that individual fails to report and is then discovered. My understanding is you all don't do background checks with relicensure, so you wouldn't necessarily pick it up absent a self-report on when somebody's trying to renew their license. Is that correct? So, but in other states they do background checks, so it could be picked up. So the attorney being aware of this is saying, we should reach out proactively to the medical commission, and then you guys are kind of in the position of what to do. So the way this was sort of brought to my attention is these come to CMT, and there's a lot of variation really in regulatory practice within the commission about what to do with these cases, and a lot of discussion about that. So I'm gonna ask you to get out your phones now and answer this question, just based on that little limited amount of information. What's your predisposition to opening an investigation? No fair to look how the things are trending before you answer. I fully expect to see a diversity of opinions here. That's the whole reason we're having this discussion. So we've got 13 people. I'll give it a couple more minutes. I hope the folks that are calling in or on the Teams meeting are also able to engage and vote. So the good news is that it seems like maybe there's a minority of opinion that the answer should be no, based on this. A fair and about an even split of people who think, hey, based on this information alone, which arguably isn't a lot of information, warrants opening. Does anybody want to comment on why or why not they would say to open now? Dr. Chung.
Well, this may only be the first time that the person was caught, but it doesn't indicate whether or not they've had a long-standing problem. We don't know the extending issues that might have led to this point. So I think we need more information, and this is a trigger to investigate that.
That's correct. Mr. Lopez, you had a hand up?
Yeah, an investigation does not indicate any moral turpitude or guilt.
So there's no harm, no foul, just to open an investigation and look a little deeper into the facts. And I think a lot of your colleagues who answered it depends would probably also think that authorizing an investigation might provide that additional data, would help the commission make a determination. Others? Should a single DUI matter? Why or why not? Scott.
I think it depends on what's the BAC, what's the context, what was the behavior? Was this on a day or the day before there are clinical duties? I think it depends.
Yeah, all that matters, and you guys are basically going to get us quickly through a slide that's coming up, because you're hitting all the high points. Dr. Domino, did you have?
Well, I was just going to say, I mean, I thought to have a DUI, you must have, just like Dr. Chung said, you know, one time is, you must have, like, I thought, at least 50 or more times that you had probably that same alcohol level and haven't been picked up. So to me, it's just a signal there that, hey, there might be a disorder, alcohol use disorder, and we should take a look at it and potentially refer to you before it becomes a real problem.
So let me ask.
We don't know the level either. I mean, you know, if it's just, I mean, there are some, I had one case that California actually got rid of the patient's or the physician's license and suspended, and I think they revoked it. And then I think we did the same, but the blood alcohol level was massive. I mean, it was amazing this person was still alive, and that they were, you know, had some really intense and severe weird behaviors and were dangerous. And so that kind of thing comes through, and you don't know what this is. So to me, there's no harm in opening it. There is harm in missing it.
Dr. Murphy?
When I was in the emergency department, there was a statistic that all ER doctors quoted, which was on average, a DUI person, doctor or otherwise, would have to drive 350 times impaired to get caught once. And so to get caught is not a trivial thing.
Yeah. exactly. And I'm gonna talk a little bit about those numbers in just a second and where that comes from. Any other comments before we move forward? I guess I have sort of two questions. One is on the licensing side, when somebody's applying for a license, does the commission have a consistent practice for how it deals with a prior DUI? Micah, could you educate? Microphone. Sorry.
If it's over 3 years, we tend to say you can go forward. If it's more than one over the course of 5 years, we're going to refer to WPHP. If it's within the 3-year window, we're going to refer to WPHP before taking any sort of decision.
Excellent. And then for CMT, when people are already licensed and you're getting a report like this, is there a similar algorithm or consistent practice that you're using to determine when to open an investigation, not open an investigation, or do you just judgment call?
I think it's fair to say, Chris, that we don't typically just get a single sentence saying, on this date, I was arrested or I was convicted. Usually the information that goes to CMT has a little bit more context. And so the questions and the concerns that were raised by multiple people, certainly with regard to BAC, and certainly with regard to the larger context, are frequently taken into account. And usually, for cases or instances where the facts are significant, like you're looking at a 0.27 or something, the commission CMT is almost always going to at least open that case to look into the further circumstances. The last thing I'll leave you with is duration of time between when the event occurred and when it's in front of the commission is frequently a touchstone for discussion.
That all seems relevant. So Willie Sutton, famous bank robber from the 20s and 30s, I think he ultimately stole about $4 million worth successfully. It was ultimately caught by the FBI, escaped from prison on more than one occasion. I guess that's why he's called Slick Willie. So kind of, in line with this, DUI is where the money often is, I think, as you guys have kind of alluded to in your comments. So let's talk about some DUI stats. The short story is it's a little bit complicated. You really have to dig into where does this data come from, and what does it mean. There's about 1 million DUI arrests in the United States annually, but it's estimated that there's about 127 million impaired driving episodes. So by far most impaired driving episodes in the United States each year go undetected by law enforcement. There are widely varying estimates of how many times somebody drives impaired before they are arrested. And I think there's reasons to be somewhat skeptical of these numbers when you actually try to go to primary source of where that data comes from. It's a little actually unclear, even though it's often and repeatedly cited. I think of other things in medicine that are often repeatedly cited, but not necessarily rooted in good data. For example, many of us have heard 300 to 400 physicians commit suicide every year. That data is inaccurate, but it's almost always cited when you hear or read anything in the medical media about physician suicide. And I could go into details that I won't bore you with right now about why that data is erroneous. It's more like about 100 to 120. But I think it's somewhere. I think it's something, to tell us, one, because there's more impaired driving episodes per year than are ever detected. I think it is, I think the data is at least good enough to tell us that usually people don't get caught the first time. There's also good data, high quality data, that first time DUI drivers have a higher rate of substance use disorder diagnosis and higher lifetime risk for 3.7-fold lifetime DSM psychiatric disorder risk, 2 times prevalence, lifetime, and 12-month SUD risk in DUI versus National Comorbidity Survey population estimates. National Comorbidity Survey is one of the largest and most robust epidemiologic surveys of mental health and mental illness in the United States ever conducted. So that's our comparator. First DUI has 7 times risk of repeat versus never having a DUI being somebody who then gets their first DUI. And binge and heavy binge drinkers have higher drinking and driving episodes by self-report. So all of this data taken together suggesting to you exactly what you said a few minutes ago, that even a single episode of a DUI is not something to take lightly. It's often a signal of, it's often maybe the tip of the iceberg for more that might be going on. When we often get referrals from attorneys and self-referrals in relation to a DUI, and our approach is similar. I mean, first of all, our general approach for any referral is the individual gets a pretty extensive health questionnaire, toxicology testing, a cognitive screen, and a 2-hour clinical interview with us. That's our initial assessment process for every individual referred to WPHP. So we have a fairly robust intake and initial assessment process to determine what's going on and what next steps might be. And in a number of cases, if a DUI is referred by you to us, we're going to do this process. And in a lot of cases, we can rule out any further concern. Coming to WPHP, as you will see, is not going to railroad you into some type of 5-year health support agreement with us. About half of people that get referred don't actually end up in any type of monitoring arrangement with us. We're able to clear any concerns of impairment, move them along. We're always here if there's more to the story and they need to come back. But our initial process, which is a lot more robust than most physician health programs in the country do, is designed to do that, to minimize the hassle and the expense and the inconvenience of a complex diagnostic evaluation outside of WPHP if we can help people avoid it. And in these cases in particular, we're able to rule out impairment or concern for impairment and move on. But as you mentioned, Scott, timing of the arrest, what time of day was it? What was the relationship of the timing of that arrest to their work schedule? What were the circumstances? Was it an incidental stop for a taillight that was out, or something else that was maybe tabs expired versus dangerous driving, crossing the median, running a stoplight? Was there an accident or an injury involved in the DUI arrest? What was the attitude, demeanor, and behavior of the individual when they were stopped? Were they hostile and belligerent, or were they cooperative with the process? Did they refuse testing at the roadside? What were the circumstances that might say that there's something more concerning going on? What was the BAL versus the observed level of impairment by the officer on the scene? That gives us an indication of tolerance, right? Obviously, somebody walking and talking with a BAL north of 270 is going to be somebody that we're going to be concerned about. Most of you, I would suspect, would not be in any condition to try to even attempt operating a vehicle at that BAL level. So if you are, you're an experienced driver, but also a very experienced drinker. And you're probably experienced at drinking and driving. I think that that's worth mentioning that people who have alcohol problems often drink and drive on a daily basis. And so they're able, they're actually careful and they're practiced at driving under conditions of impairment. And that may sound funny to say, but we're actually very practiced at doing medicine under conditions of impairment, sleep-related impairment. And we know neurobiologically that sleep-related impairment is just as impairing as impaired driving from alcohol. So this idea of practiced performance under conditions of impairment should not be something that's foreign to us or surprising. But somebody who has a high BAL and is driving reasonably well for a long period of time could have a very significant problem. And that's why I say, some of the times when I hear some of the discussions that go on, I hear there's no evidence of impairment in the workplace. And I'm like, oh, that's not reassuring to me. I know that sometimes you all as regulators think that that's reassuring. From a legal perspective, it could be challenging to make a case for impairment when there's no evidence of impairment or lower standard of care being provided in the workplace. But from my perspective, and what I know about care being, our ability to provide care under conditions of relative impairment or with conditions that could be impairing, I find it to be a little reassurance. The goal is to proactively identify illness before something happens in the workplace that can be difficult to come back from professionally. So drug and alcohol assessment is often ordered as part of a DUI legal process. And so getting our hands on, we will ask individuals who have had a court-ordered drug and alcohol assessment to provide us with that information. And we'll review that to see what was found. And then, of course, we'll look at law enforcement court documents and other records. So pretty fairly thorough look at a DUI in order to rule in, rule out concerns. I would say, even though we're often able to rule out concerns and move people along, we often find illness that needs to be addressed when we get a DUI. And it's, oftentimes the cases are, this is an exemplar of the community. This is an individual with no prior disciplinary issues. Their colleagues are writing letters of support saying, I have no concerns about this individual's ability to practice safely, so on, so on, and so on. Building a case that there's nothing there, but then we learn that there is more there. So, and in this case that we're talking about, the data provided suggested a highly competent, respected physician known for their clinical acumen, leadership under pressure, no prior disciplinary professional liability, patient care concern issues, and character letters being provided to support their safety. So what is our model? What is our process? We are a voluntary, confidential, therapeutic alternative to whatever bad things might come to you if you decide not to work with WPHP. Most of our referrals are coming from employers or credentialing entities when they have a concern that an individual's performance is being impacted in some way and they're not sure what's going on. But one of the things on their checklist is we need to rule out a health condition. It might be that an individual has 400 delinquent charts and has been, absent from work a fair amount, and they're wondering what's going on. Oftentimes, illness doesn't show up as illness. We're not getting the report, this individual has intoxicated at work. Intoxication at work is very unusual. That's a very rare report. It's usually other things, interpersonal difficulties, not playing nice in the sandbox with other, interprofessionalism issues, performance issues, not following institutional policies and procedures, a whole host of things that are sort of illness adjacent, but are the downstream effects of when somebody might be ill, but is not performing up to expectations. Usually a change, right? It's not that this individual has always been a problem, it's that this individual is having new problems when they weren't having problems before. We provide accountability, safety, and earned advocacy under those circumstances, and we notify you when we need to, which is fortunately not often. Statistically, we had a banner year last year. You could see the referrals were up. It was our best year in the last 5 in terms of referrals and admissions to the program. So we're seeing an uptick in program referrals and program involvement. And I believe that this is actually a latent effect of several years of decreased referrals and decreased involvement because we're seeing a lot worse acuity now. More complicated cases further along, and that can sometimes mean more referrals to you because actually the sicker people are sometimes, the less likely they are to work collaboratively with us. And in that case, they may need to come to you. Referral reason breaks down very generally into about over 2/3 of our cases actually are for non-substance related conditions. So people think of WPHP as substance use disorder impairment, but the reality is that we're getting referrals for psychiatric conditions, problematic workplace behavior, an increasing number of medical concerns related to that can be impairing. We have a whole person case management concierge model for people who are referred to our program. The dark blue are the services that we provide directly in-house, and then we use WPHP approved referral resources for independent evaluation outside of WPHP. So when we can't clear people through that initial assessment process, we're going to recommend an independent evaluation. That can sometimes be locally with experts that we trust locally, who are qualified to evaluate safety-sensitive workers and the job-specific work demands with safety-sensitive workers. But you have to understand that not everybody is willing to do this. Making judgments about individuals' fitness for practice incurs medical and legal liability that not every, the individual's primary care provider is often not willing to opine as to that individual's safety to practice, rightfully so. They may not be qualified to make that opinion. So, so actually the people I worry about the most are the people that are all too willing to make an opinion about somebody's fitness for practice based on very limited information. And we see that side of the coin as well, and that's worrisome to us. Then if treatment is recommended, we have a whole cadre of treatment resources that we've cultivated over many years so that we make sure that people get the absolute best care that we can to get them restored back to practice safely. And that is the goal. Yes, Dr. Chung.
What are some examples of the workplace behavior issues? Because the reason I'm asking is because I think at most hospitals, the medical staff deals with the so-called disruptive physician.
Yeah.
You don't usually think about, oh, let's send that physician to WPHP. That's more about, just dealing with their, I guess being disruptive in the workplace.
Yeah, I'd say it depends. I would say, one, those hospitals should be thinking about sending them to WPHP as part of the progressive remediation pathway. So I don't want to get somebody who, had a bad day and got into it with a nurse or a colleague and it was a one-off event. I do want to hear when that individual has been coached, maybe they've even been they're getting put on a FIPI. That's about the time when I want the institution to think about making a referral because it's not too late. If there are, about 19% of our disruptive behavioral referrals convert to substance use disorder. So they're being referred because they're not getting along well and there've been multiple incidents or complaints about their behavior interpersonally, and they want to say, is this, could this be hypomania? Could this be an agitated or irritable depression? Like they're thinking in terms of let's rule out a health issue on the pathway. We don't want to be disciplining somebody who might be sick, and people are often not willing to acknowledge or talk about ways in which they might be sick in the context of these kinds of discussions. But if we can rule that out, it's all the better. The institution then knows that they're not disciplining somebody that's sick and they need to follow their organizational policies and procedures. But if they are sick, we can often remedy the problem. So the disruptive behavior goes away when we get at the underlying health issue that is driving it. And often the other issue is burnout. Is this disruptive behavior like the consequence of a burned out clinician who is just very irritable and demoralized and unhappy with their situation? That kind of comes up, I think, in those discussions from time to time as well. And certainly we can help with that and help address and assess burnout. So I guess I don't know if I'm answering your question. I think that medical executive committees and others who are looking at this behavior within their institutions, I would just encourage them more to think, again, going back to that idea of illness doesn't show up as illness, it shows up as these other things, and thinking about making a referral to WPHP. They're not doing that. All I can do is say we need to do a better job of elevating awareness about what it is that we do and how we think about that so that we could be a support to those institutions, because I know that beleaguers people in leadership positions for sure. Did that sort of answer it? We'll say more and maybe I can get closer to the answer. You said it, you don't think about that as you don't think about illness as being connected to disruptive behavior.
Yeah, I mean, I think maybe that's just the point.
Yeah.
It's like the PHPs in most, especially maybe in this state and in other states, I think it's usually seen as, oh, that's where you send physicians when they have a drug issue or they have suicidal thoughts or,
Yeah.
that kind of thing, but not necessarily if they're, throwing instruments and yelling at people.
Right. And to your point, I mean, sometimes people have been doing that for day one and they've been doing it for a decade. And so there's definitely personality pathology inside of this too. And we can't fix that. we wouldn't consider that classically impairing from the perspective of the things that we can identify and fix. Oftentimes those referrals have I can tell you what the prognosis is walking in the door with how much responsibility they're willing to take for the behavior when they come and talk to us. If they're unable to take any responsibility for the behavior and this behavior is justified, and, you know, because if you had to work in the place that I had to work in, you'd do this too, kind of explanation for the behavior, I know that we're unlikely to make significant headway. At other times, however, we have had individuals who say, I know I have an anger problem. This has been going on too long. I need to deal with this. I'm ready. And so then we can get that individual hooked up with coaching, counseling, and other supports that's aimed at a longer term remedy for a long-term personality-based problem. So I think I would just go back to the idea of illness doesn't show up as illness. And I think health systems and institutions could do a better job of looking at performance in general and then asking the question, what are the kinds of things that impact performance? Is it a competence issue? Is it a health issue? What might be driving this? And what is our appetite for rehabilitating this individual? And then thinking about, well, the PHP is a great opportunity to potentially rehabilitate or get a sense of whether this problem is, in fact, rehabilitatable. What is the prognosis? So get closer to an answer. So yes, Mike, do you have can we get Mike a mic?
On the previous slide, if the commission makes a referral to WPHP and you have that initial assessment, do you always have an independent evaluation, or can somebody jump right into a health support agreement without the?
Typically not. So nobody gets to a health support agreement without having some independent, because we don't diagnose and we don't treat. So we're going to rely on an outside individual to provide diagnosis. There's reasons for that have to do with conflict of interest. And I will tell you, we are looking at bringing evaluations in-house. There's one other physician health program in the country, Colorado. They do their own evaluations. They do them free of charge, which obviously is a benefit. Some of these evaluations can be $3,000 to $7,000. They're often at out-of-state facilities because we don't have qualified evaluators in Washington for some of this stuff. So it can be at a significant cost and inconvenience to the individual. If we were able to bring those in-house, we would remove that barrier. That said, we would then be at risk of being said to be self-dealing in terms of the monitoring. So are we finding diagnoses that we can then monitor because it benefits us somehow? The economics of that don't play out, so I'm not too worried about it. We actually would do better to find less illnesses to monitor because it costs us a lot in resources to monitor, and we get the same amount from the license surcharge, regardless of how many people we monitor. So you could say that we would be incentivized to not find problems and save ourselves the staffing costs. So I think that's manageable, but that's a long-winded answer, but actually gets to another part of where we're going developmentally in terms of trying to take that initial assessment, which is pretty extensive, and just extend it a little farther to go ahead and provide our own diagnosis and determination as to whether the individual needs monitoring.
I asked that because of the economic issue.
Say more.
The cost to
Right.
a person we refer to you under our statute 175, and then you want an evaluation, the cost shifts to them, not to us.
Right. Exactly. As I said, we can provide help and reassurance. Most people have stuff going on. There is illness there. There are things, and we have resources to help support them. But only about half of people who get referred to WPHP. If we're trying to railroad people into health support agreements, by the way, you hear me saying health support agreements. We no longer use the term monitoring agreements. Language is important. And monitoring, nobody wants to be monitored. Nobody wants to be a monitor. So we're trying to be sensitive to some of the elements of this that can feel or be experienced as punitive just due to language alone. So our goal is to support an individual's health, believing that healthy doctors provide better care. So what is it we're trying to accomplish with these agreements? We're trying to accomplish a healthy, high-functioning clinician. So we're calling them health support agreements, and if our goal is to railroad people into those types of agreements. You can see by the numbers here that we're doing a terrible job. So I don't think that's our goal. And as I mentioned earlier, most of our referrals are for non-substance. So we get this ER doctor in, we find a PEth of 190. They're also positive for cannabis use, which was not reported when we did our health screening. And their attitude and demeanor is one of evasiveness and not fully forthcoming with their history. Oftentimes they'll tell us a drinking history. We'll get a result like this back, which says this is not a teetotaler, which is what they initially reported. It's kind of like one of my colleagues used to joke, your tax return is just your initial offer to the IRS. And so when people come in and they're telling us a story, we understand that people are not necessarily going to give us the whole story. We get some data back. We get a little bit of additional information. Then we say, this data is not consistent with what you told us previously. Do you care to revise your report? And interestingly, many people will then revise their drinking history based on the knowledge that we're not believing what you told us the first time. Oh, you know, there was that. I was in Maui for a week. I completely forgot about that. I must have been drinking a lot more on my vacation. Those kinds of adjustments to the story when we come back with the data and ask for additional conversation. So in this case, we would recommend a comprehensive diagnostic evaluation at one of those fancy out-of-state evaluation centers because we don't have any in Washington. That would resulted in this case in a diagnosis of a severe alcohol use disorder, mild cannabis use disorder, and not surprisingly job-related PTSD for an ER doctor who sees a lot of tough stuff. Recommended for residential treatment in a facility specializing in the care of safety-sensitive workers. Not an uncommon outcome. So, you know, again, we can clear people and say this DUI was no big deal. Error in judgment, not bad illness. But sometimes we do find stuff, and it's important to get that individual then treated so that they can move on. So they complete treatment, enroll in a 5-year substance use disorder health support agreement. And in this case, which is often the case, when we are able to verify back to you all that this individual is in a health support agreement following with WPHP, these cases get closed without any public action. And in fact, I will see if I asked you about this. Let me say what a health support agreement includes so you know what that is. So individual case management, all folks in our program have an assigned clinical coordinator who's a master's level clinician, licensed counselor, licensed social worker who shepherds them through the WPHP process, is their point of contact for anything that they need that might be going on. For substance use disorder participants or those who are expected to be abstinent in order to maintain mental health, random on-demand toxicology testing. We have a workplace liaison always. So there's somebody in the workplace who knows this individual, has regular contact with them, who can report to us if they see any behavioral indicators. We give them training about what the behavioral indicators are of illness recurrence and when they should call us, and then they provide us with quarterly reports and as to that individual's ongoing safety to practice. Same with their healthcare providers. So if part of their agreement, they're expected to see a psychiatrist or counselor, primary care physician, sleep specialist, whatever the case may be, we're getting reports back that that individual is adherent to their treatment and that there are no concerns. Expectation for community mental mutual support meetings for those who have substance use disorders, including doctor, health professional specific caduceus meetings, which exist. They're called caduceus meetings. There's several around Washington State, and IDAA gives people access to where those meetings are occurring and how to attend. There's also a number of online virtual support meetings specific to physicians, and then obviously online recovery support that's not specific to physicians. Ideally, we want physicians in profession-specific meetings, but also in what we call street AA or recovery meetings. We do workplace reentry, reintegration support, accountability and advocacy. Oftentimes, third parties like employers, credentialing entities, health plans, and others need reassurance that the individual is safe to practice, depending on the professional circumstances that got them to us in the first place. And then we have, and I don't think this is widely known, I think people think, oh, nobody's going to like to go to WPHP, and that's true. Most people do not like being referred to WPHP, but those, the vast majority, which I'll show you some data in a minute, have a positive experience in the program, and many stay connected to the program for many years. We just celebrated our 30th annual WPHP reunion, had a very high attendance of alumni and current participants who've been coming back, some all the way back to our very first WPHP reunion 30 years ago. So people stay connected to this community of support long-term and find it to be beneficial. These are how kind of our agreements break down. As you can see, even though only about 35% of our referrals are for substance use disorders, a fair number of people who are in are in a health support agreement are in a substance use disorder agreement. Some of that is an artifact of the fact that the health support agreements are 5 years, whereas the psychiatric and other types of agreements tend to be 1 to 2 years. So we're going to just accumulate more people in health support agreements for substance use disorder over time than we will have. There's more churn for the non-substance use disorder agreements. Our health support agreements, as I mentioned, encourage treatment adherence. We know that getting the treatment that works. And that's really, I mean, you'd like to think that, oh, it's the accountability, it's the toxicology testing, it's the fear of negative repercussions that keeps people healthy. No. That is part of it. That will get you to the dance, but it won't keep you there. What really works is making sure that people are getting the appropriate treatment for their condition longitudinally over time, and that care management that we're providing in a chronic illness management model, I believe, is what drives our effectiveness. Reduces risk of impairment should illness reoccur. Again, we're watching. So it's not unheard of that people will have illness recurrence, whether it's substance use, mood disorder, anxiety, what have you, but we can manage that within the program because we see it earlier on. We can get them help that they need, make adjustments to the treatment plan and so forth. You have reassurance that these individuals are safe compared to the unknown cohort with unknown health status out there. And we know that recurrence and relapse risk, especially for our substance use disorder participants, is low compared to the general population. We also have data that professional liability risk is lower in program graduates. Data out of Colorado established that several years ago, but we had early data that was never published from WPHP and Physicians Insurance that also showed that WPHP participants had lower risk of claims for professional liability than people who had never been involved in the PHP with Physicians Insurance. Kyle.
2 questions, Chris. Within the psychiatric component of the folks that you have under a health support agreement, I assume that covers people that have personality disorders. Mm-hmm. What percent of the psychiatric patients are personality disorders as opposed to something else?
I can't tell you.
Is it frequent?
I'm going to guess about a third have co-occurring personality stylings or full-blown personality disorder.
Okay. Unrelated question, follow-up if I can.
Yeah.
For the benefit of the commission members, how important is the last part of that slide that you showed a couple slides back with regard to the commission not taking public action?
Oh,
how important that, I mean,
I think that's really important. I think it drives utilization in the program. I think it's nice to be able to tell people that when they participate in this process, I'll give you a counterexample. We do have other boards and commissions who want to issue a STID. And the reason I didn't go into this in more detail to say you should, so we tell them they're okay, they're in our program, we're going to monitor them, and they say, okay, well, we're going to put them on a STID to order them to stay involved with your program. It's not necessary. Because if they're not compliant with the program, we have a statutory obligation to report them to you. So there's no way they get out without you knowing. So the STID is kind of unnecessary, but it's a National Practitioner Data Bank report. It will have negative professional consequences for them. And we really want people to experience the professional benefits of participating in the program voluntarily without having negative professional consequences. It encourages help seeking. When people come and they then get professional sanction anyway for having done the work that they needed to do and worked with us, that I think that sends the wrong message and a discouraging message. Yeah, Dr. Chung.
I wanted to add a little bit to that too, and maybe that's something that the commission has to kind of think about how we would. It may be a fine line. So, for example, let's say this particular individual, there was no DUI. It was, let's say, self-reported or a colleague reported, referred where, hey, I smell alcohol on you, and reported it. No complaint to the commission. They go through your program, everything's good. We never even know about it.
Right.
And it's all good, right? Because he's treated, back to work, no harm, healthy physician. If they happen to come through us, let's say the colleague reported it to us, or in that particular situation, then it becomes commission business. And I don't know if we have a way for us to take action on it to say, okay, well, we're going to take action to refer them to you, make sure they go through the program, and then we monitor them from a license point of view for like 5 years. And I say this because we've had people like that. And we're like 5 years later, we're like, why are we still watching this person? And so like you were pointing out, that usually comes in the form of a STID, and so that's always bothered me a little bit, where, in those rare cases where there's no patient, involvement, there's no harm done by anybody. We just kind of came to us and we acted on it because we're supposed to. But, just kind of wonder, like you said, we don't want to discourage people from using the program because they see us as disciplinary, even though we try not to be, right?
Yeah.
So.
And I can't answer what you should or shouldn't act on. That's outside of my lane. I would just say in a case that's simple and straightforward like this, my experience has been the commission has chosen to close cases without taking action from a disciplinary standpoint, because by the time it gets to that point, they're already well engaged with us, and we can verify back to you through paper that they're okay.
Closing is in different stages.
Right.
I mean, there's closing before we even do an investigation, and then
Right.
there's closing after the investigation has been done.
And that's usually that's what I'm usually talking about, is like they get referred to us during the investigative stage. And then the investigators often will just kind of, we'll be in communication. The investigator will call us, say, I've referred this individual to you. They're coming willingly. They get a hold of us. We close the loop with the investigator. Yep, we've got them. We'll keep you posted. And we walk them through the process. And if they're remaining compliant with that process through all of that, then it gets to the point where you're at the stage of what to do with the investigation. And then that's what I typically have seen, is that's when the cases get closed. In lieu of a STID, as long as they have. But there are other times when they're coming to us through the STID. The discipline is already happening, and that's okay too. I'm not here to judge that process. I'm just saying that in this very specific type of case, there are opportunities to close at the investigative stage when people have properly engaged with WPHP. And that's typically what the commission has done. That makes sense? You guys can continue to have discussion about that process, how it works for you, so on. This slide is just, this slide is like the quick take home message is, when we are forfeiting somebody's confidentiality, you don't know about them, and we're telling you about them, you should be worried. Because why? Because we have to report people who are clear and present danger to the public. But that's not the threshold, actually, for us to make a report. But that's typically what we're looking at, is like a level of concern about their safety to practice. But also the statute says that if they don't follow our recommendations, we have to report. But usually in practice, our understanding of that is we will have to make an assessment. Are they not following our recommendations? And do we really have enough data at that point to say that this individual is impaired and there's a concern? And in some cases, we say no. In some cases, there's just not enough there. The most common case would be a self-report, somebody self-reports to WPHP, I'm having some difficulties with my mental health. They come in, they start the process, and they say, yeah, I don't think I want to go forward with this. And we're like, there's not enough there. There's no indication of impairment. We don't want to saddle you with a complaint that we don't think you're going to have anything there to act on. And I have discussions with the legal staff about those kinds of cases all the time. Is the porridge too hot, too cold, just right? Do you want to hear about a case like this? Do you want this case to be reported? When I'm in doubt, I just call and I talk to the powers that be and I say, is this a case that you think the commission should be aware of? And I get direction from staff when I have questions. But by and large, when I'm not calling and I'm just sending a letter and saying, this individual is somebody to be worried about, you should be worried. And you should know that you can always request our records on cases by statute of the individuals that we refer. So just as the numbers broke down last year, we had a banner year last year. And I say that sort of sarcastically. We don't like having to forfeit confidentiality, make reports. We had 16 reports to a regulator last year. 11 of those were to you guys, 10 of those overall, not to WMC, but were in the case in development pre-monitoring stage, and 6 of those were individuals who were in current monitoring, typically failing out of monitoring and then needing to be reported. So WPHP, grab your handy app. I know we're a little bit over time, but we start a little bit late. Do I have time, Amelia, if people are willing to sit here? Okay. We're getting close, guys. So we notify you that a practitioner may be unsafe. You're going to see a letter and it's going to say some things. What should you do? And you can select as many of these as you think might apply. I know it's a lot of responses to read through. And there's no right or wrong answers. Although you guys are saying that the last one here is the wrong answer. So I find that encouraging, because I do want, you all to know that when we're sending somebody your way, there's probably something there worth looking at. We have seen some cases where things have been not looked at that could have been looked at, and I process that with the legal team, and we talk about, we look at, was there something that WPHP could have done differently in terms of how we reported the case to have affected a different outcome? Was the outcome what it should have been? Do we like that outcome? Is there something the commission needed to do differently in terms of how it handled things? So we do a lot of, Monday morning quarterbacking of things, and, just trying to make sure that collaboration is working the way that it should be, and that the system is really working the way that it should be to make sure that we're rehabilitating professionals and protecting the public.
Chris,
Just bring up any thoughts or questions?
Add one real quick note for the benefit of the commission members. I want you to know how relatively unique that level of cooperation and collaboration between a PHP and a state medical board is. And that's, Chris and I were, I think, celebrating that yesterday, just in a brief conversation, because it doesn't happen very often. There are PHPs out there that are antagonistic to their, and vice versa. And it's a tribute to the staff, Mike, Rick, Gina, and the work that they do to kind of maintain the relationship that's been built with WPHP, because it's invaluable. And it makes everything more efficient throughout the disciplinary process. And I would like to think benefits the folks who do need assistance of some sort. It's unusual.
And I have a deep respect for regulation. So I mean, I've learned a ton because of that collaborative relationship. These guys are teaching me all the time nuances of regulation. So I might be like, well, I don't understand what happened in this case. Why was this case handled in this way or that way? And then, you know, I'm able to talk to folks, even sometimes the AGs, looking at it through the legal lens. And then, you know, when it's explained, I learn a lot. And I think that helps us also do our work better, you know, just building that knowledge base over time about how regulation works. Because we're doing something very different than regulation. But always those conversations have enlightened me, and I'm very grateful for it. Moving on. So yes, well, before we move on, let's look at your answers really quick. So I love all of these answers and the frequency with which you say that. I mean, I think it's, you know, from my experience, one of the things I was talking to Mike about this yesterday, the staff attorneys are very much more likely than when I first came to WPHP to reach out to us when they're drafting STIDs and orders that involve WPHP, because sometimes there are nuances of how those orders are getting drafted and how they're involving WPHP. For example, somebody that we may not be willing to work with anymore, and you're ordering them back to us. And for our own reasons, we're not going to be able to work with them. So that's not a solution. Or what would be the conditions under which we would be willing to work with them? So how we stage it. I want this individual to have to, there's a current case where I want that individual to, not current, nothing we've talked about in the last 2 days, but there's a case, and there are cases where I might sometimes ask that the individual go do an ordered assessment before they come back to WPHP versus coming to order to come back to WPHP and get an assessment, because the assessment becomes the bar or the hurdle to get over in order to get entry. Then we have all the data from the assessment and can make a better decision about re-engagement or re-entry into the program based on what the evaluators found during that assessment, if that makes sense. So those nuances get sorted out much better. And I think much more effectively and efficiently by collaborating on the front end before the ink is dry on that order or that STID. So I just want to quickly go through outcomes and remind you that this is, you know, your program. You authorize us to do this work. We couldn't do this work without you, and so we owe you some outcomes data. You have a very extensive Department of Health report that's part of our Department of Health contract. It's in your packet. But just quickly, you know, as I mentioned, 90% confidential participation in the program, 87% of participants report needing and benefiting from our advocacy. 75%, 3/4 reporting full remission. This is unheard of in mental health and substance use disorders. I'm just telling you, I've been a psychiatrist for a long time. It's one of the reasons that I do this work, is because the outcomes are so dramatically different in the work that we do here. Some would say that's a healthy doctor effect. I don't think so. I don't think addiction and mental health cares that you have a medical license. And I've treated lots of health professionals outside of the PHP model and have not gotten anywhere these kinds of results. So I really do think that this model is offering something unique and special. 98% of program graduates are in full or partial remission, meaning they have some residual symptoms. That's pretty remarkable as well. 86% are abstinent at 60 months in our program, because we track 60-month abstinence in our program, versus, you know, at best, half of people will be relapse-free at 6 months in usual care. 6 months versus 60 months. We have less than half the rate of burnout of professionals. Latest data from the Shanafelt group at Mayo and AMA puts health professional burnout, about 45% of health professionals reporting a significant symptom of burnout. We've historically been well below that. Benefits of program participation extending beyond the impairing health condition alone. High rates of reporting of helpfulness of the program, with 1 out of 5 reporting the program has been life-saving. We actually drilled down and presenting data on suicide risk in PHP participants at the American Conference on Physician Health next month. We have good data to show a protective effect against suicide for individuals referred to our program. As I said, people come through the door feeling one way about the program, and they often leave the program feeling very differently. So at program exit, you can see that almost 2/3 of people involved in the program felt that their impression of the program got better over time in program. So I think sometimes I hear conversations here and amongst the other referents that we use, healthcare employers. Everybody worries about referring to PHP and being experienced as punitive. I would say, That makes about as much sense as saying a lumbar puncture is punitive. A lumbar puncture might be a necessary and life-saving medical procedure that somebody needs to have. Is it painful? Is it uncomfortable? Is it burdensome? Sure, absolutely. But the outcome that they get in terms of their health may be well worth that pain and discomfort. We have some pain and discomfort associated with our program in the early stages. But I think in the end, these data provide a contrast to that concern that what we're doing is not kind, not compassionate, and not caring. Advocacy, as I mentioned, is really important to our participants. They need somebody vouching for them. And we are that voucher, and that support is considered very important to our program participants and program graduates. I think this is a really important metric. Is like, you've been through the program, how likely would you be to refer somebody who might be similarly situated? And I think these numbers are very strong. I mean, clinical staffing continues to be a challenge for us. Our toxicology testing and third-party administrator for toxicology testing continues to be a challenge. We're now looking at a variety of other options, including becoming our own third-party administrator, so not having a third-party administrator for our toxicology testing. A number of system redesign issues, quality assurance processes underway. We have a very robust strategic communications plan. In 2 weeks, we're going to be filming our first WPHP brand video. We recognize that awareness, kind of going back to your question, Dr. Chung, is one of our big challenges. We do great work. We provide a ton of benefit to those who come to our program. We're the best program you probably never heard of. And if you have heard of us, you probably maybe not heard the best things. So we really need to do a better job of getting the word out and explaining what we do. We provided other, lots of additional services. If you're not signed up for our newsletter, you can get our newsletter. It's a quarterly newsletter. People like it. We get a lot of positive feedback about our quarterly newsletter. We curate some of the best content around physician and health professional wellness and well-being resources and information that you might be interested to know about. As a result of that, we also are on LinkedIn and Facebook. If you follow things in social media, it's just a way to keep updated on what we do, what we're involved in. We're doing a ton of advocacy work around credentialing reform. I just worked with the Washington State Credentialing Group to once again revise the credentialing questions to no longer ask about anything other than current impairment. When individuals are doing credentialing, the Washington Practitioner application is the most widely used credentialing applications by health systems and health plans in the state. So that will be a huge win for us when that gets over the finish line. In terms of, we also did credentialing reform with Physicians Insurance this past year, with the University of Washington has been a leader in credentialing reform. I'll be at NAMS this year talking about credentialing reform in Portland. So lots of things that are going on behind the scenes to, again, reduce barriers and help promote health and well-being, remove system discriminators and biases that can result in people being reluctant to seek care. You can go to our website. You can read the testimonials and success stories of participants in the program. Their voices, their lived experience in the program goes beyond just the data to help reassure that what we're doing is really benefiting people in profound and meaningful ways. You're all welcome to throw in any questions or comments in the Slido there at the end. The audience Q&A will hopefully bring that up for me, although it's not staying on that slide, so I'm not sure. But please feel free to unmute your mics if you're online and you've been wanting to participate, or ask me any questions or comments or reflections at this point. Yes, Dr. Chung.
So this reminds me of the slide that you showed that had burnout rates lower than the general population, the provider population. Reminds me of some of the data that came out of surgical enhanced recovery programs that are actually meant to make you stronger than you were before surgery. So you don't just come out of surgery being as strong as you were before. You're actually stronger because of what you've done to prepare, right? So in this sense, what can you guys do that's more proactive, right? Because we were just talking about this morning, that the medical commissioners were reactive still, and we're trying to think of ways that we can be more proactive. And by and large, what you guys do is also reactive. You react to people either self-reporting or people who come to you but can you make a dent in, let's say, the burnout rates in a general sense by being more proactive to the population of providers?
Yes and no. So ways in which we've been proactive is through our education outreach efforts. So we tried, we've been available. I mean, there have been years when I've done 70 presentations in a year, getting out to as many health systems and organizations to talk about issues related to burnout, organizational drivers of burnout, consulting with health systems and health organizations, working with the WSMA. They just did a Thriving in Medicine report to help CMOs around the state think about what's the best ROI for reducing burnout and addressing mental health. I work with the ACGME. I'm the chair of the affinity work group on addressing barriers to access for mental health treatment for our residents and fellows. So there's a lot of work that we're doing in those domains to try to be upstream. But we also have to be careful. We're a small organization with a limited budget and limited resources. And the further we get upstream of impairment, the more we're dealing with more of almost a kind of public health mission. Which, we've had many discussions with our board of directors about, what is our core mission? Is it to really be reactive and protective in these cases where we're, serving these participants who are in some type of difficulty, or is it to step back and have a little bit of a broader mission? And I think through we're investing a significant amount of resources. We built a communications team over the last year with an eye to where can we be effective in our education and outreach and communications mission to be a little bit more upstream. That's probably where we see that fitting for us, if that makes sense. There's a lot to unpack there because, again, we see the need, but we also can't be all things to a health system that needs to be doing a lot more to support the workforce. Yes, Scott.
Thank you so much, Dr. Bundy. I actually was squarely in the it depends column, and I think you and Dr. Murphy and Dr. Chung have persuaded me it's probably always open and refer. Could you just briefly tell us about your SUD evaluation versus, you mentioned earlier the court-appointed SUD evaluation, and I just want, I want us as commission members to understand the difference between the court-ordered SUD evaluation, which is often performed by somebody who is not, I've seen people who don't even have a GED. They took a couple of weeks of training, and I've been doing criminal defense for quite a while, and people in jail tell me ahead of time, oh, I'm going to get an ASEM 3.5 because I want to go to inpatient instead of being in jail, or I need to come in at 2.5 so at IOP so the state will pay for the first month of this. And some of them say, no, I'm going to get it. They're actively using in the jail, and they're telling me, no, I'm going to get an NSR. So they know what to say to people. So I just
Absolutely.
ask, let's not rely on the court-ordered SUD if that comes in.
Yeah, I mean, I think it's a developed talent to be able to listen to a story and to do the kind of interviews that we do and ask the kinds of questions that we can ask. And actually do that repeatedly in different ways and then corroborate that with toxicologic evidence. I mean, these court-ordered evaluations, I don't see a lot where they're actually getting any toxicology testing. It often is an interview with somebody who has dubious qualifications. All of our folks are as I mentioned, licensed at the master's level, often dually licensed with SUD, substance use disorder professional licensure, in addition to being a master's level counselor or social worker. And having 2 physicians on the staff who are overseeing all of these cases. So I think that the evaluation, I mean, we look at the court-ordered evaluation because it's a data point to see what happens, but we don't put a lot of stake in it. Yes. Mike for Mike.
Just quickly, back to the cost issue. when the commission makes a non-disciplinary referral to WPHP and they come and do your assessment, and then you determine this was not a one-off, you need a CDE, and then they have to bear the cost rather than us, and we have a statute that requires us to pay for a formal evaluation. What about us at that, you telling us that, that you recommend that they undergo a CDE, and then we issue a notice of intent to order mental examination, and therefore the cost shifts back to us? What do you think of that idea?
I'm very open to that idea. If you were open to it. I mean, that, you know, I've had those discussions practically with staff attorneys when we've been like trying to figure out how to get, you know, we sometimes are dealing with people who are destitute and they're not going to be able to go get the evaluation on their own dime. And I've seen the commission compassionately make a decision to go exactly in that route, because that will actually get the person moving forward in the process. And, you know, it's career and potentially life-saving. So I'm definitely open to us working that pathway if it's available. I really appreciate the extra time that you've given me for today's presentation. It means a lot to me to be able to get in front of you once a year and have this discussion and hear your questions, and know that I'm always available to you, either directly or indirectly through staff. You know, we endeavor to be of service, and hopefully you find that we are. Hopefully you will also let me know. And one of the big issues of that gives me tremendous amount of trust in the commission is that you've also let me know when I needed to improve something. And so it's all well and good to, you know, be joyous, happy, and free in the work that we do together, but it's also nice to be able to get that critical feedback when we need it in order to make our mission the best it can be. And I thank you for that as well. Take care. Good luck to you the rest of your summers. We'll see you at the next meeting.